titanium meshes. The titanium mesh is fixed with titanium screws, and it restricts the growth of bone in the orbital region, which is why in pediatric patients cases you have to remove the mesh, and the time given is around 6 months.
Okay, so now we move on to the next topic and the last topic of the IC, which is proptosis in children, and how should we approach these cases. Now it's sometimes whenever we see a child walking in with proptosis, the first reaction is of what is this and how to manage it, how to go about it. And parents are very apprehensive. The child is crying, irritable most of the time. So what do you do in this kind of a situation, which is a little tough situation in the OPD when you're seeing routine cases and then suddenly you have to see one such case. Now the best thing that I would like to suggest is that don't panic and just create a systematic algorithm in your mind that will help you to always manage these cases properly and to proceed in the right direction step by step. Don't jump to the diagnosis straight away. First, you should just try to classify a few things in your mind beforehand. You should know what you're looking for actually. What are the possibilities that may be going on in the orbit of a child? So if you know the possibilities, only then you are able to proceed in a proper systematic manner. If you don't know the possibilities, what can be there, then obviously it's very difficult. Firstly, one has to classify these lesions into benign and malignant ones. Now, benign lesions which are commonly seen in children are cystic lesions. These can be infectious lesions, neurogenic lesions, vascular, histiocytic lesions, bony lesions, degenerative lesions, or it can be because of trauma, in which case the history would be clear. The most common malignant orbital tumors which need to be kept in mind are rhabdomyosarcoma and leukemia. Although there is a vast list of malignant tumors, but these two tumors should come up front in your mind whenever you see a child of proptosis, if you are suspecting a malignancy. Now the approach is we should first try to see if the process which is there causing proptosis, is it confined to the orbit or has it extended outside the orbit. Second question that you should look for is which orbital space is occupied by this lesion. And many times with the first clinical examination you are able to make out a lot of information, you are able to get a lot of information, but many times you also need to rely on imaging. So then your history should proceed accordingly. Once you know what all is possible, then you see where exactly is the lesion, what direction the globe is displaced in, then you ask appropriate history. That will tell you the age of onset of the problem, whether it was congenital or acquired, what was the duration and pace of evolution, was it a very rapidly enlarging lesion, proptosis is increasing rapidly, is it increasing slowly, is it static, is it not increasing, since birth child has proptosis and it is like this only. Then you know that you most likely are not dealing with a malignant lesion, it's probably some sort of a structural thing which is there. Ask for associated pain. Pain may be because of neural infiltration of the tumor, probably because of the mass effect, probably because of inflammation. So you think more in terms of those things. Ask for any prior surgery. Ask for any familial genetic condition like neurofibroma. If there is a family history and there is a child with proptosis, then probably you start thinking in direction could be something related to neurofibromas, and always try to look for old photos where things are not very clear on history. A thorough complete examination has to be stressed, and you need to do a complete examination of the face, visual acuity, color vision, as far as the child allows. Exophthalmometry if it's possible. Do retropulsion, see how much pressure is there behind the globe. It's a soft thing, it's a hard thing, that will tell you. Then look for asymmetry in color in eyelids. If it's a reddish colored eyelid, there is a hemorrhage. If there is an S-shaped eyelid deformity, all those things will take your diagnosis in a certain direction, step by step. Temperature, whether the temperature of the skin is raised, indicates an inflammatory thing. Is there a pulsatile mass, if there is a palpable mass. So all these things you have to see step by step. Then you look for ocular motility, look for function of the third, fourth and sixth nerve. Look for any conjunctival chemosis. That chemosis would indicate probably there is a signs of engorgement of the vessels close to the apex. Look for AC cells, anterior chamber cells. They are often seen in inflammatory conditions and even sometimes in leukemia. Always see the retina. Sorry. And rule out Roth spots. They can tell you straight away there is some pathology which is there with the blood, there's something going on there. So you look for proper, your examination proceeds in a direction step by step, history, then examination. Then based on your history and examination, you go for an appropriate imaging. Suppose you suspect something which is there in the apex, you would like to get an MRI done. Especially in children, as far as possible, we want to get an MRI done unless we suspect a bony lesion or something which is arising from the sinuses where we may need a CT scan. But MRI is usually our preferred modality. We don't want to expose the child to risk of radiation. And if there is a history of probably or suspicion of a cystic lesion like Histiocytic, USG can even be sufficient. Always rule out pseudoproptosis. Now, many a times we feel that the child has proptosis, but if you look at the axial length of the child's eyes, then you see that the child has got high myopia. You just need to do refraction. That is not proptosis. Don't go on imaging unnecessarily. Child with staphylomatous eyes, that's not proptosis. You need to do an ultrasound though, but may not need any other investigation. Congenital glaucoma may appear as proptosis and may present as proptosis in extreme cases. You need to rule out any pressure changes, look at the other eye. And then sometimes you have sockets which are shallow and they also may lead to an appearance of proptosis. Moving on to the benign lesions, cystic lesions. Dermoid is the commonest one. It comprises 40 to 50% of all pediatric orbital lesions. And these may be superficial, deep, or sometimes they are combined, having a deep component which passes through the bone and has a superficial component. These are called dumbbell dermoids. The approach and treatment is basically excision, and wherever the dermoid is located, you would try to excise it with the minimum possible scar. Sorry. Timing of excision depends on the size of lesion. Now, ideal is that you excise a dermoid when it's small, when it's still small, and not let it grow too much. As soon as the child is fit for anesthesia, you can excise it, and that will give you the smallest scar. Look for presence or absence of globe displacement, look for any inflammation. And nowadays, for all these angular dermoids, which are fairly common, we've shifted to a small lid crease incision. And you can see that, this was a very large dermoid, but you cannot even see the incision underneath. You can actually manipulate and try to squeeze out the dermoid even through a very small incision, and that leads to minimum scarring. Infections are serious, and children can have orbital abscesses. They need to be imaged properly, and this child actually had a cavernous sinus thrombosis. So if this is a situation, you need to be really, really aggressive in managing them. Sorry. Now this child had proptosis and a diffuse irregular extraconal mass in the orbit. What we suspected was some sort of a tumor there. To our surprise, on biopsy, it turned out to be a fungal granuloma, and the child was taken up for debulking surgery. The granuloma was debulked, and the child put on long-term antifungal therapy, and they did very well on prolonged antifungal therapy. Treatment had to be given for about 6 months, and all the active infection resolved. Myocystic is fairly common in our country, and you need to do a proper imaging, ultrasound or MRI or CT, and then treat medically. Most of these cases don't require a surgery. This patient presented with a proptosis in the left eye, lacrimal gland was enlarged, and FNAC revealed tuberculosis. Then there can be inflammatory lesions like dacryoadenitis, where you can have a classic S-shaped deformity of the eyelid. Do a Shermer's test, a reduced tear secretion on the affected side goes in favor of an inflamed lacrimal gland. Other inflammatory pathologies can be reactive lymphoid hyperplasia, idiopathic inflammation, which is relatively less common in children. Thyroid, again, less common. And sometimes there is a foreign body which goes unnoticed in cases of children, and that may lead to a granuloma formation. Neurogenic lesions like glioma will present with axial proptosis, papillar edema, decrease of vision in a child, and sometimes they are associated with neurofibromatosis. You need to rule out systemic features of neurofibroma, and the management depends on the extent of the neurofibroma, the status of the visual acuity, Chemotherapy is preferred for children less than 3 years of age. Radiation is preferred for elderly children. And if the eye has no vision, then even surgery can be considered to excise the glioma. Neurofibroma can affect the orbit either in the eyelid, or it can be a diffuse neurofibroma of the orbit, as in this case even the muscles are infiltrated by the tumor. Then there can be vascular tumors. SEMA has already shown capillary hemangioma. Systemic beta blockers are now currently our preferred treatment modality. Then other vascular tumors in children can be lymphangiomas. These children give history of increase of proptosis whenever there is cold or cough or a sinus infection. And in these cases, sometimes you use steroids to suppress the acute phase, and then once it's settled, then debulking can be done to remove part of lymphangioma. Some people even use sclerotherapy to collapse these lymphangioma. These are basically low flow venous malformations. And then there can be AV malformations which may affect the brain, which may affect the orbit. So you need to investigate these children properly. This child had AV malformation in the brain as well. Management of these cases is very tricky. And again, another child who had a variable proptosis, you do Valsalva maneuver, you do the head bending test, and you will see that this child had a AV malformation behind the eye. Another patient who presented with bilateral subconjunctival hemorrhage, loss of vision. This patient was a patient of aplastic anemia. Look for systemic causes in these situations. Trauma would be obvious. Histiocytic lesions can also be seen in children. These are slow growing lesions and respond to steroids. Sometimes chemotherapy may be needed in these cases. Bony lesions which can be seen in children are fibrous dysplasia, aneurysmal bone cyst, osteomas, and sometimes congenital orbital asymmetry, which may lead to proptosis. Moving to the most important malignant orbital tumors, rhabdomyosarcoma and leukemia. These are the two which should be kept on the top of the list. Rhabdomyosarcoma is the most common orbital malignancy in children, and most common presentation is at 1 year and 7 years of age. Sometimes they can even have an acute inflammatory kind of a presentation. This is one of Dr. Santosh's patient who responded beautifully to a multimodal